Good afternoon. I was introduced a little bit earlier, but my name's Karan Patel. I'm a clinical oncology doctor and clinical research fellow at the Christie. So thanks very much for your time. Dr. Metcalf asked me to speak a little bit about tumour mutational burden in adenoid cystic carcinoma and salivary gland cancers. Some of it is in the kind of sphere of the immune cells, not directly, so it's really helpful to hear Ben's question earlier and some of the questions that have been given earlier. Before I delve more into tumour mutational burden, I think it's always helpful to take a step back and talk about what our general aims are at the Christie and our salivary gland research, and something that Dr. Metcalf's been doing for some time. We've known for some time now that genetic mutations can be some of the driving forces of many cancers. So our aim is to comprehensively characterise some of the changes we see in these rarer tumours like adenoid cystic carcinoma and salivary gland cancers. We also know that genetic mutations on their own don't tell us the full story. We don't really know how a cancer might behave just from their genes per se, if we just look at the genes. So we're trying to tie in clinical information with the genetic changes we see to learn more about these and the way it can help us predict how tumours may behave. And I'll step this way of the mic. And the other thing we're particularly keen on focusing on, which I think Professor Van Harpen mentioned, is we're very keen to characterise genetic changes that might be what we call actionable or targetable, i.e. ones that might lead to treatments, and we can call that personalised medicine. And this brings me to tumour mutational burden, something that we've been looking at for the last 6 months. We define it as the total number of mutations in cancer cells, and we often use the number of mutations per megabase, and megabase being 1 billion base pairs. And I've included that little diagram which shows you the rungs of almost a DNA ladder. I'll quickly point. Sorry for those at home, but these little rungs are what we call bases, and changes in those are what we call the tumour mutational burden. So tumour mutational burden has been looked at in a number of different cancers, and it's been found to be a very complex marker of cancer function. Tumour mutation burden can be a mark of the cancer-generating properties of a tumour. So we've got these two DNA strands there, or two lots of DNA strands, one looking relatively clean, let's say, the other having these red crosses that I've put on, and they represent mutations. And the cell that's in green, that looks relatively unscathed. The cell in red, it's got more changes in it. It's got these circles on the inside and circles on the outside, and those represent the products of all these mutations. We know that, or we think that, the more products these mutations are making, the more problems they're creating, and the more oncogenic and cancer-generating that cell is, unfortunately. Tumour mutational burden can also mark the how immunogenic a tumour or cancer cell is. So that red cell again on the that I've shown, on the outside of the circle, on the outside of the cell, we have these little molecules. The more molecules that are on these cells, we think, makes it more recognisable to the immune system. And in turn, we know that the way immunotherapy generally works is by helping the immune system recognise cancer cells. So the idea is that if there's more of these products or proteins for the immune system to recognise, and then we're using the immunotherapy to amplify it, then maybe tumour mutational burden for some cancers is a mark of how responsive that cancer might be to immunotherapy. And with all those things combined, tumour mutational burden in some cancers can be associated with prognosis. This is a box plot of lots of different cancers that have been genetically profiled. Truthfully, unfortunately, salivary gland cancers aren't on here, but what I want to show you is how actually variable tumour mutational burden is across a number of different cancers. The ones on the far right are ones with higher tumour mutational burdens, and overall these are ones that are linked with better responses to immunotherapy, and the ones on the far corner show much lower rates. This is an international phase 2 trial from 2020, and what the researchers did, they looked at or looked to see with the effect of pembrolizumab immunotherapy on those patients with what we'd call tumor mutational burden high tumours, so with a TMB value of greater than 10, and compared it to those that had tumours which had a low tumor mutational burden, and they categorised that as less than 10. We can see on the chart or the graph above, patients who had lower tumor mutational burden unfortunately had shorter durations of response than the blue line. And you can see the line just straighten, and that's because that was the response to the treatment just carrying on for a bit longer. The graph below looks at the fact that overall, those with higher tumor mutational burdens, i.e. once again tumours that had a tumor mutational burden of greater than 10, had better shrinkage rates. This trial did include some patients with salivary gland tumours, but very small numbers. And we can see that only 3 patients actually had tumor mutational burdens of more than 10. I think that fits in with some of the things that Dr. Van Harpen was saying. From that study, the US Food and Drug Administration did approve the use of pembrolizumab immunotherapy for solid tumours with a tumor mutational burden of greater than 10 in cases where unfortunately one treatment hasn't worked so far and when there wasn't felt to be very satisfactory alternative options. And the last slide of our background really is, this is a 2017 study by other researchers who used genomic profiling to characterise tumor mutational burden in a series of salivary gland tumours. And what they found overall is that salivary gland tumours, which overall are faster growing, had higher rates of tumor mutational burden than those that might be overall typically slower growing. So salivary carcinomas had, I think, a 14% rate of having tumor mutational burdens greater than 10. And we can see in adenoid cystic carcinoma, it was actually only 1% of patients looked at that had a tumor mutation burden of greater than 10. So I'm a little bit short, so I think I just keep going back and forth, so apologies. So that really brings on to what this research area is about. What we wanted to find out more was what the distribution of tumor mutational burden was in adenoid cystic carcinoma in more detail, and also other salivary gland cancers. We want to see if there was an association between tumor mutational burden or some of the some of the known genetic changes that we already know about in that tumor type. And we also want to see if there was a link between tumor mutation and prognosis. This is a table just outlining some of the characteristics of the patients we looked at. On the first column are patients that we looked at who are from the UK. And in the second column are patients from America who were looked at or under the research team of the Memorial Sloan Kettering Cancer Center. The median age at diagnosis was around, so that's the average age at diagnosis, was around 55 and a half. Slightly more patients were female than male. And in terms of where we biopsied them from, or the tumor, the genetic analysis for the biopsies we looked at, about half were from metastases, so spread, and about 40% were from primary tumor. And that's helpful for us to work out where we're looking. I mentioned that we wanted to look at the association between tumor mutational burden and some of the genetic changes that we already know about in adenoid cystic carcinoma. One of those is Notch mutation. I think it has been talked about already this afternoon and morning. Unfortunately, Notch mutations can be associated with faster growing disease and worse prognoses. We also looked at where people had sites of spread to also better understand if tumor mutational burden might be linked to these. And also we looked at average tumor mutational burdens. And we can see that both in patients from the UK and in America, overall, the values would be on the lower side, which does fit in with a less immunogenic profile. This is 2 graphs looking at whether we feel there's an association between tumor mutational burden and prognoses. On the graph to the right, we can see that these 2 lines are pretty similar. The red line are those with what we call a lower tumour mutational burden for this group. So what we did was split it by the average. So the red line is those with tumour mutational burden lower than the average, and the blue line is those with a tumour mutational burden higher than that average we saw. And as I said, it doesn't look like there's really much of a difference. When we look at those tumours with notch mutations, it does look like that a higher tumour mutational burden may be associated with a worse prognosis. We also looked at tumour mutational burden in other salivary gland tumours. And once again, we looked at patients from the UK, and we looked at some patients that under the Memorial Sloan Kettering Cancer Centre in America. Once again, there were slightly more women than men. In terms of where we took the biopsies from, the majority were from the major salivary glands, so these are the salivary glands like the parotid or the submandibular or the sublingual. And in terms of where the biopsy sites were taken from, about 40% were taken from the primary tumour and about 40% were taken from the area of spread. We looked at actinic cell carcinomas, adenocarcinomas, mucoepidermoid, myoepithelial carcinomas, and salivary duct carcinomas in the main. So quite a variety of salivary gland tumours. And we saw a higher tumour mutational burden, but in the context of that study I talked about a little bit earlier, where they made a cutoff of tumour-based mutational burden of 10 to be maybe a marker of response to immunotherapy, it is quite a bit lower. And this is a box plot similar to the one that we saw right at the beginning that we made ourselves, looking at the averages and the distribution of tumour mutational burden in these other salivary gland tumour types. And on the far left, we can see that salivary duct carcinoma looks to have a higher tumour mutational burden than some of the others. And once again, we would associate salivary duct carcinomas overall as being typically maybe faster growing than other salivary gland tumours. So to conclude what I've been talking about, we feel it's really important to look at these things in order to actually know, one, the biology of the tumour, and two, to help predict what might work and might not. Overall, I think we did find that tumour mutational burden is quite low in adenoid cystic carcinoma. It does fit in with this pattern that overall adenoid cystic carcinoma, to an extent other salivary gland tumours, do have a lower immunoprofile, and that's something to build on. Tumour mutational burden doesn't seem to be so helpful in prognosticating patients on its own, but when we look at some of these subgroups, like those tumours with notch-activated pathways, then it may help us or guide us to know how these tumours might behave in the future. And lastly, although tumour mutational burden is overall low in adenoid cystic carcinoma and other salivary gland tumours, it does show that there is a slight difference between those that might be more fast growing and those that can be slower growing. But thank you very much for listening.